Yeah, John's been coming up to help me learn how to do cryoanalgesia, and it's been pretty great. I mean, before it was pre-COVID, we actually had a chance to go out together, which was really fun and seemed like a long time ago. But it's really a pleasure. I want to thank you all for inviting me to come speak. It's hard to believe it's been 10 years. Since I was on faculty at UCSD. And hopefully you can all see my slides. Yeah, nod if you can see my slides. Excellent. Okay. I thought we would come up with a topic. I actually was texting with Rodney Gabriel just to figure out what would be of interest to people if I came and talked about some topic related to medicine. Sometimes I give talks on topics less related to, or at least less strictly related to medicine, which is also fun to talk about. But I thought one of the great opportunities in having speakers visit your department, even virtually, is to just get a feel for ideas. And sometimes those, since we can't have the face-to-face real life interactions and conversations that often come around visiting professor time, I thought maybe if I gave you some thoughts, then maybe that'll keep those conversations going where you are. And please feel free. It goes without saying, but reach out to me anytime. You can call me. Many of you still have my number. You can email me if you have any questions, ideas that you want to discuss. If you're looking to try to get more involved in professional organizations, I have some experience there too. Feel free to reach out if you need an outside mentor. So a couple of things. I have no disclosures. And I wanted to just dial the clock back a little bit. This is what UCSD regional anesthesia looked like when I left it in 2010. Much smaller group. The main hospital was Hillcrest Medical Center, where I spent most of my time. And I think I saw Dr. Drummond was online earlier. Dr. Drummond was chair when he hired me. He was looking for someone fellowship trained in pediatric anesthesia. So the reason I ended up at UCSD in 2004 was because I'd done a PEDS fellowship. So it kind of goes, it's sort of a long story and we don't have enough time for that. But just the short version is that I started my academic career, actually my first job on July 14th, 2004, working at Hillcrest. At the time, same-day surgery was closed on Wednesdays, so I worked in the main OR. Bill Mazie, who's online, good morning. He asked me in my first day as an attending if I would be the late call person that day. I had a great day working with 2 third-year residents paired up with first-year residents on my first day as an attending, and we had a couple really great cases for peripheral nerve block, and those peripheral nerve blocks that I did that first day as an attending were the first peripheral nerve blocks performed by that particular CA3 resident in all of his residency. And so it goes without saying, I guess, if you fast forward to the future, I've had a lot of really interesting experiences, and I've had a lot of great advice. And Bill, because I accepted my late call assignment, that first day as an attending, let me choose my room for the next day. And I got to meet Linda Collins, who was, as many of you may remember, was heavily influential in terms of attending assignments. And Bill and Linda put me in same-day surgery Thursday and Friday. It's where I got a chance to work with Reed Abrams and Matt Mounier, who in hindsight now, or at least later on, they told me that they basically gave me the benefit of the doubt because I was a new person. I didn't know how things were done. I contacted them the day before to offer regional anesthesia to their patients, and they basically thought to themselves, let's see how this goes. So if the story about Benioff is actually an interesting one. We had a junior senior faculty retreat for an evening at Bill Mazie's house, and it was a few months in. By that time, I had been asked to start a regional anesthesia rotation for the residents, and that's when John, who of course I knew by reputation but didn't know personally, he came up to me during that dinner and basically said, I know this isn't what you came here to do, but it seems like it's going really well, so maybe you should stick with it. So I thought, well, that seems like good life advice. So I stuck with it. And Tony, who we were chatting a little earlier, I finally got serious about doing academics, I didn't know a thing about doing research. I mean, I published my first paper, a case report, when I was a fellow. I had pretty much avoided research for all of my undergraduate and medical school and residency until basically almost the end of my training. Yeah, Tony made time. Yeah, you can see the Post-its behind him. He did the same thing for me. I sat in his office down at Hillcrest. He put up 3 blank big Post-its on his windows, and we brainstormed ideas. And he was willing to be a mentor on my first grant application. It didn't get funded, but I learned a lot. And I also, probably one of the biggest lessons that I learned was really that you have to make time for people. And so, so throughout my career and for the rest of my career, I'll always make time for people, just like Tony made time for me. I had so much support when I was there. Mark Wallace, when we decided that we would have a separate acute pain service, Mark was one of the most supportive people I can think of. He gave me great advice, continues to give me good advice. We saw each other at the ASR meeting when we still had meetings back in the fall. And then I also have to give a lot of credit to Jerry Manicky, who was interim chair for the first 4 years out of 6 that I was at UCSD. And as an interim chair, you have a lot of pressure and not a lot of resources. And so Jerry and I always had a good understanding that if I had some crazy idea that I wanted to try, then I always got a lot of moral support. And even I always had to sort of scrap together the financial support in many ways. But Jerry always supported me. He always gave me his confidence. And I told him that if anything went wrong, I wouldn't blame him. So yeah, I would always take it. And I learned all about billing. I learned about billing from Jean Franciscello and Belinda Fitzgerald, who I think were great teachers. They're non-clinical, of course. This is when the department had its own internal billing service. I had to learn about billing so that way I could get Brian Ilfeld to come to UCSD. He came in 2006, we didn't have a block room model with a separate regional anesthesia attending in the first couple of years. So I would cover a couple or more rooms over in outpatient surgery and also do regional and then do some rounds in the Tower and Hillcrest. But in order to get Brian to come with his incredible research mind, I really had to set up a system in which we had a separate regional attending. And Bill was incredibly supportive of that. Linda, Jerry, I just had to figure out a way that we could make ends meet. And that's where Jean and Belinda really came in. So that's the short version of regional anesthesia at UCSD. I'll give you the long version sometime when we can see each other in person. All right, so let's talk about what we're going to talk about. I thought I would start with, this is an opinion-based slide, but I thought I'd start out with what I see as the 5 lamest topics and debates in regional anesthesiology and acute pain medicine. These are the ones that come up frequently in meetings. Sometimes you get pro-con debates at conferences on a panel, or you might see paired articles that may also cover some of these topics. But they include opioid-free anesthesia, single injection blocks versus catheters, the latest, greatest interfascial plane block, adductor canal versus local infiltration for knee arthroplasty, and anything related to liposomal bupivacaine. That pretty much covers, I think, the majority of topics that really have very little interest in general. I'm going to cover opioid-free anesthesia because there's not enough time to cover all of these, but I thought this was one that has obviously exploded in the last couple of years, and we'll talk a little bit about why that's happened and really what I think would make the most sense in terms of acute pain medicine and adapting to the opioid epidemic. So I thought I'd cover just 3 things and have hopefully some time for questions. As I mentioned in the beginning, that this is a really, I see a lot of the virtual lectures and visiting professorships to really be a good opportunity just to put out ideas that hopefully get more conversations going where you are, and hopefully you continue those conversations with each other. So these are the 3 things I really wanted to cover. I mean, how did we get here? So why are we even talking about opioid-free anesthesia in the first place? Because if some of us will ask, well, didn't we already have this? You know, isn't that called regional anesthesia? But there's been a movement, you know, more recently just because of the obvious opioid epidemic. And before we were hit with the COVID-19 global pandemic, the opioid epidemic was really front and center in most of anesthesiologists' minds, surgeons' minds, yeah, and those who deal with pain medicine and addiction. Yeah, definitely had the opioid epidemic really as the highest public health priority. And it makes sense because I think this is before we lost 170,000 Americans to COVID-19, but the opioid epidemic was already killing 130 Americans a day from opioid overdoses. And I think this is really important for us to keep in mind when we think about delivering opioids, not so much, not strictly in the operating room, you know, but dispensing opioids for acute injury, for pain, and after surgery. And I think we have to recognize the fact that surgery has something to do with prescription overdose. And I think this is important because even for what we consider relatively minor procedures, we know that up to 7% of those patients who were previously opioid naive will go on to develop chronic opioid use. And that makes that really, if not the most common, one of the most common complications after surgery. And we don't really talk about it that way, but arguably we should talk about it that way. We should, just the same way that we counsel patients about other risks from surgery, I think the risk of being chronically on opioids should be considered a potential risk. And we know that there have been multiple different responses, one of which was the CDC's prescribing guidelines for opioids in chronic pain. This came out in 2016. It's been used in various settings, not just for chronic pain management and opioid prescribing. And because of that, I think that there's been a fairly wide swing of the pendulum from one end to the other, you know, from the fifth vital sign where we used opioids basically to try to dull patients' consciousness in order to get lower verbal rating scales for pain, to now thinking that maybe we should avoid opioids entirely. This is being considered for revision right now. It's an ongoing process. UCSD has great representation with Mark Wallace being a member of the opioid work group. And so we're hoping to see some updates coming soon about this particular prescribing guideline. But I think one of the challenges with managing the opioid epidemic, at least from my point of view, is that much of the legislation and regulation with regard to opioid prescribing has preceded evidence. We don't have good studies on, one, like how long pain actually lasts. We don't know, what the subgroups are necessarily for various pain trajectories after common surgeries. And we don't know the trajectories for opioid cessation, which is not necessarily aligned 100% with the pain resolution trajectories. And besides all of that information which we lack, we also don't necessarily understand which patients will go on to develop chronic opioid use. So despite the fact that we have no evidence, or at least very little evidence, we have lots of legislation and regulations. So more states than not have already set prescribing restrictions based either on pill numbers or arbitrary days. And I think this, unfortunately, is the reality. So even though we are still actively trying to understand and research this particular area, we already have laws that restrict our ability to prescribe. And I think this is a challenge because while at the same time we understand that the opioid epidemic is a problem. We know that patients can get opioids and can stay on them for a long time after surgery. And this has affected people's practices. So this is the reason why the pendulum swings. It's because we know that there have already been lawsuits over prescribing. There have been civil suits related to wrongful death. These are all concerns, I think, for physicians who are responsible for prescribing potent medications like opioids. And I think at first, I think that this may have been somewhat effective. So yeah, this is, of course, not, yeah, you can't develop causal relationship or conclude causation from this. But if you look at the trends, you can see that there's a flattening of this commonly prescribed opioids curve, at least as it relates to opioid overdose deaths. What's probably more shocking in this particular graph is that the opioid epidemic is not one thing. Yeah, it's multiple things. And while we tend to focus on prescribed opioids, you can see that's really not the current problem, at least not the major contributor to opioid-related deaths today. It's really the abuse of synthetic opioids. And then, of course, heroin has actually surpassed commonly prescribed opioids. So I think that this is a real issue for us. And I think we have to pay attention to the fact that the opioid epidemic, while often slapped with one label, is really not a homogeneous problem. So if you look at the other direction, so now, based on actually the author's response for the CDC guideline, we know that the use of the CDC guideline in inappropriate settings is at least partially responsible for highly restrictive opioid prescribing. And now, we've received notice from the FDA, CDC, and other regulatory bodies to make sure that we're giving enough opioids. So it's the advice kind of goes from one end to the other, and I think this is really confusing for physicians who are responsible for pain management. What is the right thing to do, and how do we respond? How do we take care of patients the way that we know they should be cared for, but at the same time be responsible and mitigate risk? And I think that's really key. We know, and this is from some of the authors for the CDC guideline, that the misinterpretation of much of what's out there in terms of guidance is unfortunately potentially harmful to patients. And I think that we have to take that very seriously. So anytime we consider guidelines, and I just worked on one on behalf of the ASA with the American Society of Breast Surgeons to come up with pain management guidelines for breast surgery. And it's important that while we want to mitigate the risks of opioids, that we don't hold a line that says that we should be completely anti-opioid, only because this is an effective class of drug that's been around for thousands of years and does have appropriate indications when used appropriately. So where is our evidence right now? So we're talking strictly about opioid-free anesthesia. Opioid-free anesthesia is an interesting concept that, as I mentioned in the beginning, it doesn't seem like it's really new, only because many of us didn't call it that before. We used to give opioids when you think that it makes sense to give opioids. For a patient who has a great regional anesthetic, a spinal anesthetic, you don't give opioids because they don't need them. But interestingly, because of the opioid epidemic, and this is just one of the Einstein quotes that I tend to use a fair amount especially when we talk with our fellows about adapting to change. In every crisis lies great opportunity. And if you look at some of the publications that have come out just in the last few years, specifically about opioid-free anesthesia, they tend to be fairly clustered in this last decade. And a lot of that has to do with, obviously, because of the attention on the opioid epidemic. And some of these have gone fairly specific. And if you look at, this is one article from the Oshner Journal, published a couple of years ago, and they actually call it an opioid-free anesthetic prescription. And they talk about using lidocaine infusions with dexmedetomidine, half a MAC of isoflurane. They say if you have a shorter procedure, then you can just give bolus doses of lidocaine and dexmedetomidine. And I'll tell you that the evidence to support this and comparisons or comparative effectiveness research comparing this to other alternative techniques is truly lacking. So when you think about the concept of opioid-free anesthesia, I think this is really it's really embedded within anesthesiology. It's within anesthesia practice. It really doesn't stand alone. At least it doesn't make sense in my mind that it should stand alone. Yet, we already have a society for opioid-free anesthesia, and I've been criticized for actually pointing this out. But you can look this up yourself. So if you look up the Society for Opioid-Free Anesthesia, you can see a little bit more about who founded it and what it's about. But the concept to me, I think, is kind of crazy, only because why would you set up a society, a professional organization that is purely based on not using a class of drugs? Like, it does not make sense. We don't have a society for paralysis-free anesthesia. And there's a reason for that. It's because I think as anesthesiologists, we really are, we tout ourselves for being clinical experts within medicine, physiology and pharmacology. We should understand the risks, benefits, indications, pharmacodynamics, pharmacokinetics of the drugs that we give, and we should give medications appropriately when they're indicated and in the most appropriate doses based on patients' needs. I think this makes the most sense to me in terms of an approach. And I think opioids fall into the same category, at least the same approach and algorithm for use. I was able to satisfy one of my academic career goals in using a quote from The Princess Bride in a paper. And this is actually an interesting story, only because opioid-free anesthesia has been fairly popular, at least within the academic literature related to pain medicine. And I was asked to write an editorial about a paper that was submitted to the journal Anesthesia. And so I think it allowed some freedom. This is my friend Nabil from Penn that wrote this with me. It allowed some freedom to ask some important questions. And I think that this idea of opioid-free anesthesia, while it sounds attractive, is not very well defined. And one of the figures from our paper, I think, hopefully highlights this, is what is this time for opioid-free anesthesia? And when you look at some of the protocols that have been published, including the one from Ochsner Journal that I mentioned earlier, they tend to define the time for opioid-free anesthesia strictly inside the walls of the operating room. So from the time that the patient enters the operating room until the time that the patient leaves the operating room, they do not give any opioids. But the patient may get opioids in the PACU, and the patient may get admitted to the ward and get an IV PCA for hydromorphone. That patient may already be on opioids before they come to the hospital, and then very likely when they get discharged home, they will get a prescription for opioids. And so the question, I think a big question for me is, what does it even mean to have opioid-free anesthesia in the operating room? Does it actually make a difference? Or are you just restricting arbitrarily one class of drugs when it probably is indicated at times for the patient who's having surgery? If you look at some of the literature, the European Journal of Anesthesiology had a pro-con, published a pro-con debate that was held at one of their annual meetings. And it's interesting because the pro article from the speakers from the panel actually states that we're not yet opioid free when it comes to anesthesia and analgesia. We can deliberately withhold opioids. I mean, of course, all of us can do that, right? If you give like someone 2-MAC, you can avoid opioids. That doesn't mean that the patient won't have a response to noxious stimulus, but you can potentially design an anesthetic that way. But it's not quite opioid-free analgesia, because really the limitation, at least the target zone for when opioid-free protocols are implemented, is so strictly limited. And so even the pro article advises a more rational use of perioperative opioids and is not strictly opioid-free. If you look at the con article it basically mentions the same thought, and I think it reiterates the importance, I think, of thinking about how we design perioperative protocols, how we take care of the patient around the time of surgery in a much more global sense, not just emphasizing the time that we have one-on-one with the patient in the operating room, but really thinking a little further down the road to when the patient leaves the operating room, and ideally when the patient leaves the hospital, because I think that is really a great area of opportunity for us as anesthesiologists to really try to extend some of the benefits and some of our knowledge of multimodal analgesia and its benefits further outside the operating room. if you look at what the literature so far, and this will be fairly short because the scoping review of opioid-free analgesia is fairly small. And so if you look at the number of studies, and this is their summary table, the way I broke it down, or at least what I focused on in this table was really looking at how many studies focused on in-hospital outcomes versus how many studies focused on late outcomes, which I think is really what we're getting at is, does this intervention, does opioid-free anesthesia decrease long-term opioid use? Because that's what really matters, at least in my opinion. That's the public health problem. It's not whether or not patients got 2 morphine milligram equivalence difference that was p-value less than 0.05 while they're in the hospital. Who cares? But did we actually make a change that impacted their downstream recovery and resolution of pain? I think that's really key for me. Did we affect their long-term opioid use? And very, very few studies have actually looked at outcomes after discharge from the hospital. And I think this is concerning for me only because does it really matter? And the same is true for many of our regional anesthesia studies. Does it really matter when you compare the 24-hour MMEs for one block versus another block, or one block versus no block, when the rest of the hospital stay is ignored and how the patients do at home is also ignored? And in my opinion, as you can probably figure out, the answer I think is no, it doesn't matter. So if you think about a rational approach, and I thought this was a really good editorial from Anesthesiology, and one of our pain physicians that works with me at our hospital is Dave Clark, and we've had these discussions about what are the advantages. And I think if you think about the use of opioid-free, at least an opioid-free protocol, we know that the evidence shows that it has very minimal effect on discharge opioid prescribing, if at all. More studies than not show negative results in terms of prescribed opioids. And it's also important, I think, that we tend to lack the association between these types of short-term interventions and long and persistent postoperative opioid use at all, which I think is a real missing link. And I think that we do want, and I think the intentions are good, we do want to find out whether or not our interventions in the brief period of time when we have patients in front of us, we want those to have long-term effects if they have them. And I know this from all of our research in regional anesthesia. We would love for regional anesthesia, when performed for the right patient in the right setting at the right duration, we would love that to have long-term effects. But even studies that we've done, looking at postoperative opioid prescribing, after major surgery with short-term blocks, we know that that does not affect a long-term opioid use at all.
Hey, Ed, it's John Drummond, and I hope you will permit an interruption and a comment.
Of course.
This is you've nicely touched on an issue that I was going to bring up, that the definition of opioid-free anesthesia is a scattered one. And here's an instance, I think, where the nomenclature gets in the way. And I wonder if you'll be the champion here. We need a new phrase, something like opiate-free discharge. That's really what we should be trying to achieve, not sending people home with narcotics, because I'm pretty damn sure that the fentanyl I used during a craniotomy isn't causing anybody's addiction. But if I sent them home with a Percocet prescription, that might be causing the problem. So new nomenclature, opiate-free discharge. I think that should really be the objective.
I think that's a great point, John. I mean, I think that it's the concept. I think the intention, I think, is good. And we would like to see interventions that we can put in place in a very brief window. And I think that's the story of anesthesia, is that we have these very brief, intense, and very life-changing in many ways experiences with patients. This is what connects us to them. We would love to have those interventions have downstream or long-term benefits for them. And we would like to see things that we do not have long-term adverse effects too. But I also think we have to look at our role a little bit differently. I mean, it's our responsibility to patients is not strictly limited to when they're in the operating room. It's not limited to the walls of the operating room or the PACU, for example. It's actually, I think our responsibility, I think, as perioperative physicians is really to be that patient's physician, at least their critical care physician, around the time of surgery, from the time that they're preparing until they have suitably recovered, and that end that the end window at least is not well defined, and I think that it should extend beyond the hospital.
Well, Ed, please be the champion. We need, stand by the notion, we need a new phrase, opiate-free discharge as an objective. And I'm going to make one more political comment here. When you do this lecture next time, I think that you should be less forgiving about the Joint Commission and the Joint Commission's role in the opiate epidemic, because it was the Joint Commission who held our noses to the stone and made pain the fifth vital sign. Pain is what the patient is. All the physicians have to have triplicate capability so that no patient goes home without his opiate. This was bloody well driven, this was driven by the Joint Commission. I was the chair of the pain committee back in the early 2000s. And I know that the Joint Commission is a contributor to this phenomenon. And I think you're too kind to them in not mentioning their contribution to the chaos that has ensued. End of politics.
No, I mean, the point is well taken, and because of that, the Joint Commission fully embraced the APS's Fifth Vital Sign campaign. They actually adopted the campaign, and back now it must have been probably 5 or 6 years ago, I was asked to be part of the rewrite for the Joint Commission in Hospital Standards for Pain Management. And so if you look at the current standards are written very differently than the previous ones. The previous ones were pretty stark. And I agree with you that there is no question that at least in the early 2000s, the way the standards were written, you would be, at least because it's hospital accreditation, your hospital would definitely get dinged if you weren't pouring opioids into your patients. The newer one, or more recent version, has a heavy emphasis on multimodal and tries to set better criteria for determining whether patients should receive PRN doses of opioid. It's clearly not perfect, and I think the problem with at least currently, with trying to adopt and adapt protocols related to PRN opioid administration, is that right now, while we have perhaps better pain scores that we can use, better tools, the routine at most hospitals is that they still just ask for verbal rating. And I think that the verbal rating, I think, is really, in many ways, preventing the implementation of better and more judicious opioid prescribing. So I think it's important when we talk about this to try to I always like to end, for those of you who've heard me speak, I always like to end on a positive. So I think that's important because there is a reason why we do the things we do. There's a reason why we enjoy innovating and asking these questions. And I think, to John's point, I think we never stop thinking about how we make things better. And I think that there's great opportunity here because clearly there's a need. The correct response to the opioid epidemic is not, well, one, is not purely limited to curbing opioid prescribing, as we talked about already. In addition, we know that we haven't maxed out the things that we can do within anesthesiology and within pain medicine to really address the issues of in-hospital and post-hospital opioid use. And so, to John's point, I think that there's a lot of opportunity here. One of the things that I think is very important to put in the forefront is that we, as anesthesiologists and pain physicians, we can't be strictly anti-opioid. It doesn't make sense. Opioids are analgesics, so we have to understand opioids, and we have to better apply their mechanism of action to the appropriate indications. We have to understand pain, and as I mentioned before, we don't fully understand pain, which I think is kind of a missing link to me, only because it seems like, that to the first slide that I showed you about some of the lamest debates in regional anesthesia, we talk a lot about single injection versus catheter, but we are still missing observational data on how long pain actually lasts after the most common surgeries that we perform. And I think that we have to reassure our patients that we are addressing their pain when we talk about multimodal analgesia, that we're not just taking opioids away, because I think that there's been a public outcry, as you can imagine, and part of the reason why this CDC guideline authors have come out with clarifications and those guidelines are being rewritten is because patient advocacy groups have really spoken up about this. And so when I've been a part of guideline creation, and currently I've been working with the National Academy of Medicine on their action collaborative countering the U.S. opioid epidemic, the group that I'm in, the pain management work group, our emphasis is pain management, and that we want to provide better pain management. And by providing better pain management, we decrease the amount of opioids people need, and we decrease the over-reliance on opioids. And we're against the sole use of opioids as an analgesic, because we have a lot of other tools. And just from this graphic, you can see that there are a lot of things that we don't always employ for patients, while these also are shown to be effective. And I think that not all of these interventions and medications are indicated for every patient. You can see that some, if you look at the items that have a cross are used as indicated, and the ones with a star are indicated as, or used routinely unless contraindicated. And I think that's a good way to think about this. And if you scan the QR code, you can get the free full text of this article. So a couple of things. If we go back to the editorial that I wrote with Nabil, I think it's really important to think about how we provide anesthesia and analgesia, and it should not be strictly limited to the walls of the operating room. And to John's point, I think that this is critical, because we should, for every patient, apply multimodal analgesia. Multimodal, at its very, very basic definition, just means using more than one class of analgesic. That shouldn't be that hard. And now I think it is a little bit of a stretch. It takes a little bit of effort to use more than two classes of agent for multimodal. And that's where, at least for major surgery, there is a performance gap. And one of the projects I worked on a couple of years ago was developing quality metrics, because up until now, or up until the release of the new quality metrics in AQI, we had 0 quality metrics that related to acute pain, and we had none. And arguably, you could say that the performance metrics we have for anesthesia don't have a lot to do with anesthesia. So the metric that we worked on was a multimodal analgesic metric, and it's currently has already been adopted by the AQI, and it's being considered by CMS for inclusion in their quality payment program. But I think the one way, and I mentioned this before, that you can actually give opioid-free anesthesia is to do pure regional anesthesia. And I think that this goes without saying. If someone has a great block, whether it's peripheral or neuraxial, you don't have to give them opioid. And I think this is a good lesson for us. That's not to say that every single patient should only have regional anesthesia, but to use that as an example, to say, well, you only give opioids when it makes sense to give opioid, and not to give opioids routinely. And I think that we also know that there are other agents that maybe not every patient should have. And I think gabapentinoids have gotten a lot of attention recently as perhaps not being effective when given routinely. And I think that makes sense. You should give them only when they're indicated. As far as regional anesthesia goes, I think this is just one of my pet peeves about regional anesthesia and outcomes, is that it's very difficult to assess outcomes when very few people get it. And in places like UCSD, many patients have access to regional anesthesia. And so that has become the norm, which I think is a huge cultural shift. But if you just talk to people, talk to your colleagues in anesthesia, even in your area, but definitely if you talk to colleagues in anesthesia around the country, this is truly not the case. We do have a problem when it comes to preparing new anesthesiologists who are going out in the practice in terms of how they learn regional anesthesia. This was not a problem, or at least it was less of a problem, I think, when I was a resident, because there just weren't that many blocks. We didn't use ultrasound and learn regional anesthesia using a nerve stimulator, POPs, and anatomy. And you could, in theory, and these were the ACGME requirements for peripheral nerve block experience when I was a resident, and it's somewhat surprising that these are also the peripheral nerve block requirements today. So this hasn't changed. So the expectation that you have an experience with patients, with 40 patients that have a peripheral nerve block, back in the day when you could say, well, if there were, say, 4 common blocks and you could do them 10 times each, maybe you could finish the residency with a decent understanding of how to do a peripheral nerve block. But today, if you said, well, 40 blocks, I could probably do 40 different blocks one time, and then I would satisfy my ACGME requirements. But if you did that, you'd know nothing, right? You would have no competency in regional anesthesia. So I think that the way we look at regional anesthesia core training has to evolve. That has to change because the field has evolved. And I think that there's some opportunity there. And I tackled the accreditation of regional anesthesiology fellowships for 3 years, which now we have dozens of accredited fellowships. And my new project for the coming years is likely going to be this. I'd like to see if we can revise the peripheral nerve block requirements for residents, because I think how we do it doesn't make any sense. Some of the thoughts that we've had about this, I wrote this editorial with a couple of our colleagues in the UK, because it's not just a US problem. So if you look at the UK, Australia, New Zealand, Canada, the way that requirements for peripheral nerve block experience are written are pretty vague, and ours is actually much more explicit than than many of the requirements in other countries. And the fact that we even have a number is actually it differentiates our requirements. But I think if you think about how best to train core residents to go out into practice and use regional anesthesia, I think we have to start thinking differently, because throwing them into a regional anesthesia rotation where, especially in a complex program like UCSD, where you're doing every possible block available, that it actually forces you to train the residents differently. It forces you to think about what is going to prepare them best, because perhaps that, QL 57 isn't the thing that they're going to be doing in their practice. And so because of that, we came up with a basic blocks list. And many people will disagree with this. I actually didn't agree with all of the ones that we listed in column A, but I got outvoted. But the idea is that you should come up within a program on what you think are the basic blocks that every general anesthesiologist should know. And this is important because I think then you can almost create like a passport book system for your regional anesthesia rotation for residents and say, yeah, these are the high yield blocks. You have to do these. And when you look at that list and you're thinking, oh, that would be cool to do whatever that new fancy interfascial plane block is, or you could do an interscaling block, then you would preferentially assign the resident to do the block that probably makes the most sense in terms of their future practice. I think this is a different way for educators to think, and I think this is a good opportunity for us just to reset. And so, so I put it out there. Like I said, every program should come up with their own list. So this is not a universal list, but to think about it, and I think that's really important. And perhaps if this moves along, I've contacted our residency review committee at the ACGME, just because I've known some of them from working on the fellowship. This may go forward, and I would like to see a better definition of what the peripheral nerve block experience is for residents. I think this will make a difference for patient care. So a couple of things, going to John's point, we have to think beyond the PACU. We have to think beyond the hospital. I think these are great opportunities for innovation, and we have to look at it that way. Just like the Society for Opioid-Free Anesthesia sees the opioid epidemic as an opportunity. I think that we have to look at these gaps. These are gaps in care, and I'll tell you right now, our experience here is that no one is fighting anesthesiology for the domain of transitional pain. No one wants it. So if that's the case, then I think that, and there's a demonstrated need, because we know that you can probably intervene before patients magically become chronic pain patients at 3 months. That definition has held true for years and years and years. And even with the new definition from the ISP, chronic pain is still defined as being, it has to be longer standing. We know that some acute pain will go on to become chronic pain, and you may be able to figure that out before 3 months. So if you can, then that's basically what defines transitional pain. It's an opportunity to intervene earlier. And I want to thank John. He has a good lead-in, because one of the things that we've really focused on here in our practice is going beyond the hospital. So We know we've set up protocols like you have, that really drive the way that we care for patients in the hospital, from operating room protocols to acute pain protocols that really stress the use of regional anesthesia and multimodal. But what we've also been able to do is actually create standardized and patient-specific opioid prescribing and tapering. And we've hardwired this into our electronic record. Based on having protocols. You have to have a very robust acute pain service in order to actually set up patients for standardized prescribing. You have to be deliberate, and you have to see and pattern your management of those patients based on their recovery. But based on this, we've been able to come up with a fairly simple tool. We've implemented this for all of our knee replacement, hip replacement, and now spine surgery patients. And the results are fairly similar. So rather than when we compared this to our pre-intervention state, which was basically arbitrary prescribing, sort of surgeon's choice, then we found that we were able to reduce opioid prescriptions for the 6 weeks after surgery by more than 2/3. And I think what's also interesting about our results is that patients are not getting more refills, they're not getting more ER visits, they're not getting admitted to the hospital because of pain, but we're actually treating their pain better. And honestly, like for some of these patients, if they used 0 opioids in the previous 24 hours, you can see that the tool is actually based on the prior 24-hour opioid use by the patients, and we prescribe them short-term oxycodone. If they use 0 tablets of oxycodone in 24 hours, then it should automatically prompt the prescriber to ask, do you even want to go home with opioids? Because you know what? Some patients say no, and that's okay. And I think that's an important point, which is that patients don't have to go home on opioids. If you have gone your previous 24 hours after a major joint replacement operation with no opioid, then there's a pretty good chance that you'll stay off opioids. So to the point about how long does pain last, this is actually a figure that was rejected from a paper, but I used a different figure. But this was published. I wrote this with Brian Oefeld and our friend Kareem El-Baghdadli in the UK. And what we did was we actually looked at data from previous randomized clinical trials, 3 of which we performed while I was at UCSD. And we had approval to look at these data again because I was curious. We had been having this discussion on social media about pain trajectories, and I've talked about pain trajectories before in different talks because I think that's really what should drive the selection of the right regional anesthetic. We don't know how long a block should last because we don't know how long pain lasts. But what if we did? And so, this is actually, these data are actually all based on UCSD patients. And I've overlapped it, even though these are 4 separate studies. But what was interesting, I think, about this, and I think if you don't get too fixated on the numbers, all of these patients got placebo infusion. Starting at a minimum day 0 or day 1 after surgery. And so if you look at their trajectory starting on post-op day 1 and on, at the very least, what you can conclude is that the pain trajectories for different surgeries vary, right? I mean, they don't look the same. They don't exactly overlap. They have very interesting inflection points. And I think based on this, I think if anything, it supports the idea that we need to study this more, because this is a small sample of RCT patients. So it has the strict inclusion and exclusion criteria that we see in RCTs. Imagine if you were to create trajectories for all patients having surgery, just as an observational study. Think about the different strata, because you'll have, I would envision multiple lines based on pain trajectory, even for a single surgery. And it would be very interesting to know which patients fall into each stratum, and what the predictors are for how patients recover and which trajectory they'll fall under. And I think that's really important. I think going forward, we would want to understand that better.
And isn't one of the problems with that graph, though, the variation around each mean?
Mm-hmm.
I mean, I can only imagine if you plotted individual data sets, it would look like true spaghetti with with patients going from never getting better to those that, as you say, within 24 hours were totally pain-free. I mean, that's the problem that you clinicians face. I mean, that's the problem. And the algorithm you showed previously about tapering, I mean, it's almost like it has to be driven on the results of that particular patient, I would say. I mean, I guess that's what you're saying, but
Yeah, you're right.
This graph, I love what you just showed, but I go, but the truth is, even if this wouldn't even work in a rat.
Yeah, I'll pull this up. Actually, I'll show you the, that was the Andy Klein from Anesthesia. Yeah, that was his request. His request was actually to substitute this, this figure. This was the original figure that I submitted for the paper, which is great on the slide. But he asked for a 4-panel figure that actually shows the errors. And so I'll show you that one just because it does show there's a wide range. And if anything, one thing, because knowing how we try to basically get homogeneous patients for RCTs, but even within that sample, there's a very limited sample of patients. You see a lot of variability, and it really makes me think that if we were to do better trajectory analysis in a larger cohort, a larger observational cohort, that we would see some patterns in terms of recovery. And I think that would be really interesting, because I do believe that how we approach patients right now is based on what we think will work for the most people. But really how we probably should approach acute pain management moving forward, if we're really trying to move towards precision pain medicine or precision medicine, is really try to figure out how we approach each stratum differently. And that, I think, is really the key. I mean, I would love to see our ability to pre-test people before they come to the hospital. Even though we talk about transitional pain as being a post-operative function, really what we do right now, we have a transitional pain service that we started a year and a half ago. We actually get consults ahead of time. And so if you look at this first figure in the upper left, if we think about transitional pain as being post-discharge, but you can imagine this is really a continuum. And so getting to the point of trying to adapt and figure out better personalized pain medicine, for certain patients, we actually need to know about them before they hit the hospital. So if we can get consults from surgeons, which we get now, in order to pre-evaluate them, know what medications they're on, know what their pain history is, and then we can often intervene. Even that may mean implementing multimodal analgesia for 6 weeks before they get to the hospital, or even applying an intervention if it makes more sense for those patients before they come. And so I think that this really is I think an interesting area in terms of healthcare innovation, just because we know that chronic pain is costly in the hundreds of billions for health systems. And I do think that what goes along with that, if not focusing so much on the money, but what goes along with that is that it's a public health problem, and it actually prevents economic contribution for many patients who are disabled because of chronic pain. I also think that this also probably goes without saying, because at UCSD, you have some real innovators in regional analgesia. I think that some of these newer interventions are not local anesthetic based, and they extend that period. So right now, local anesthetics are limited based on their pharmacology. We also know that infusion catheters tend to be limited based on retention and also FDA approval. We have peripheral stimulating leads now, so using smaller leads for neuromodulation. One type is approved for 2 months by the FDA. This extends now into that transitional period, and I think gives us an opportunity to offer different interventions for patients who may have indications for it. And I think if you approach this, this idea that regional analgesia will not always be based on local anesthetics, I think it really widens your view, and I think that it opens the door to potentially caring for patients in closer. We're not quite to an individual level, but ideally finding out if we can put patients in buckets ahead of time, and maybe identify the ones who need more care or more intensive care sooner, because I think that ideally we want to see them also recover within the same, along a similar trajectory to patients who are ideally opioid-free and less complicated. I also think that other interventions like cryoanalgesia, so this is actually old technology renewed. This is what John had taught me how to use in the last few months. I think that this has also opportunity, and the idea that you can use a non-local anesthetic-based intervention, essentially to freeze a nerve and put it out of commission until it regenerates. It may have some benefit for some patients. This isn't for everyone, but imagine that if for the patient who already has chronic pain, who is presenting for like their second revision arthroplasty, or the patient who is recovering in a much longer trajectory than your typical patient after major surgery. These types of interventions may offer some benefit. I don't think they're for everyone, but I think that we should consider these as potential tools for the acute pain physician. And so with that, hopefully I covered a few things. Like I said, I was hoping to give you some ideas and then get some people talking about things. And I think this may lead to better research questions. I also think this will hopefully get people thinking about ways we can improve patient care. So I'll stop sharing just so that way we can pull up faces, and I'll stay on for questions for people.
So this is Mark Wallace.
Hey, Mark.
Nice seeing you. And thanks for your kind words for all of us, but you get way more credit than anybody you mentioned. So with what you've done. But I see these patients, the ones that remain on opioids, and every time I get a chronic opioid user, I always do detective work and trace it back. Okay, when did it start? What were the circumstances? And almost all of them are from surgery or for some acute injury. And then the opioids stick. So that slide you put up on the tapering, that is critical. And it's hard to believe that it took this long for somebody to come up with something like that. Because if you do kind of this forced taper, now what Tony said, it doesn't work for everybody. And you are going to have outliers. And then you have to have that second step, which you did mention, of this kind of collaborative team between acute and chronic. And then make sure that you get those patients, because most of those patients have very real pain, but they also have psychosocial issues that drive their pain. But not everybody ignores that. Mm-hmm. So this was this was a great talk. I really, really enjoyed it. I think it's a very, very important topic.
Thank you, Mark. I mean, as I mentioned earlier, I really didn't do it justice, but I definitely wouldn't be doing what I'm doing if you hadn't supported me early in my career. And I think that really, it speaks a lot to the importance of mentorship and just people giving you time. That was really something that was very, it was needed because, you just never really know whether that conversation you have with someone is going to help spin them in a direction. And for sure, I mean, my experience being at UCSD as a junior faculty member couldn't have been better. I mean, no matter what kind of crazy idea I came up with, you guys always supported me. We put out, actually our National Academy of Medicine group just put out best practices and future research directions in tapering. And I was really glad that our papers our two papers on postoperative opioid prescribing and tapering were cited, because they're really right now, I mean, we use the same tool. It's not a complicated tool, but I think the guidance that's out there, at least in the surgical societies, is extremely limited. They have some recommendations, and we have a lot of great colleagues who have been working on this too. But I think that recommending general pill numbers is not super helpful. I understand where people are coming from and that you have to start somewhere, but at the same time, it has to be fairly explicit. And what people aren't talking about is how to safely taper people. And for patients, I think that that's very concerning. I mean, we have very well-educated patients who will get a pill bottle for Percocet, and it says, take as needed every 4 to 6 hours. And you know what they do is they take it every 4 to 6 hours, because they think that they're following directions. And I think that if you give them a schedule, then you make it normal. You make it okay for them to understand when it's safe to go down on dose. And, I mean, the fact that our refill rates don't increase, I think says a lot about how much patients actually need. They'll show you how much they need, especially if they're in the hospital for a short period before they go home.
Ed, would you allow another comment from me, John Drummond?
Of
First,
course.
you've given credit to your Well, exactly. Well, first thing I
You
was
made
going
it
to
my
do
first job.
with respect to mentorship, I wanted to congratulate you on surviving my mentorship, because you remember I wanted you to go over to Children's Hospital and join the cadre of pediatric anesthesiologists I was trying to build. Congratulations on evading me. The more important comment is that I heard you say at one point that the ultimate opiate, I'm paraphrasing, opiate-free anesthetic is regional anesthesia, but there is a trap that patients fall into that I want to make everybody aware of, and it's not so relevant to perhaps UCSD and Palo Alto, where there are so many continuous catheters. But out in the private world, people do a single shot block for shoulder surgery, and the patient leaves the PACU happy as a clam. But then about 2 a.m., the bomb explodes in that patient's shoulder. It has happened to 2 of my family members after shoulder surgery, and that is when they begin to pound the opiates. And I think there's a trap in regional anesthesia that does not have a well-planned transition once the patients are at home, because not everybody has stolen IM ketamine at home ready to give to, ketorolac, not ketamine, sorry, at home to give to the patients. So a trap that patients fall into that I think everybody should be aware of.
No, you're absolutely correct. And I think actually this is a good time. I'll pull up that the figure that Tony had asked about. Let's see, hopefully you can see this. This is actually, can you see the 4-panel figure? Okay, so this is the figure that we actually included in the paper, and I think to your point, John, about shoulder arthroscopy, down here in the bottom right, and these are UCSD patients, and I 100% agree with you. I think that this is part of the reason why I feel like the debate is at regional anesthesia meetings about single injection versus catheter is so empty. It's because it really doesn't incorporate the patient experience at all. It's problematic because the decision between single injection catheter is often completely arbitrary, and this is what we had written in this article as well, is that it's a clinician decision. It's not a patient. It's not a shared decision. And if you look at this as a placebo group, and the placebo group on post-op day 1, to your point, you can see the range of pain scores. The bars are 95% confidence intervals, so you can see this wide range. And so imagine that happens to you, having gone to sleep completely pain-free, and then you wake up at 2 in the morning, with as John mentions, an explosion, right? And then it's really hard to catch up when it comes to pain management. And you can see this downward trend. And I would say that we can't think about our interventions, whether it's regional anesthesia, analgesia, or something new that we come up with later. And we can't think about it in terms of how the duration based on our own convenience. We should start thinking about it in terms of trajectory. I mean, look at knee replacement. A knee replacement, at least on this graph, this goes out to post-op day 6. It hasn't even turned down yet. And so it flattens out in this moderate pain range for a week. And then later on, one of our colleagues, Professor Lavendome in Belgium, has tracked this out to 3 months. And interestingly, her data show that there's a subset of patients on post-op day 5 where their pain scores actually go up. And those are the patients that develop neuropathic chronic pain. And so I ask myself, and this is something that we talk about here within our group when it justified our creation of the transitional pain program, is who's actually following the patient on post-op day 5? Is it the surgeon? Is it the ER? Because is it the clinic? Because the patient calls and they say, "Oh, I ran out of opioids," and then the person on the phone just assumes that, oh, they're addicts. They just want more pills. When no one's actually examined those patients to find out whether they've actually gone and developed neuropathic pain. So to your point, I fully agree. I think that not only should there be a transition plan, but I would say that the right regional analgesic for a patient should actually be patterned after these kinds of data. We don't have these data for all surgeries. We don't even have these data for all patient populations. But I think you can take away from this that these are all UCSD patients. So at the very least, I would say these are UCSD clinical trial patients. So perhaps they're a healthier, less complicated subset. But even amongst these patients, you can see there's a lot of variability. And I think that the best regional analgesic, I feel like will really better match the pain resolution. And I think if we can do that, then I think our ability to have more of an impact on patients' chronic opioid use and hopefully chronic pain will change in the future.
Ed, let me ask you a question. I mean, there are two questions that come off of this graph. One is, it's kind of interesting, whether it's statistical or not, that hip arthroscopy goes down, knee arthroscopy plateaus, and that seems to be the same thing for shoulder arthroscopy. Now, maybe that's just statistical weakness of the analysis. But let's just say that's kind of true. One, I wonder why that is. But the second thing is, so I'm not a clinician. So tell me how you manage this. If this, as John said, you're in the outside world, you do a single block, you don't want to put a catheter in because you don't want to have to be responsible for maintaining that catheter. So how would you, if you were writing a journal article to explain or something to a medical student, say, if you see this, this is what you must do. I mean, realizing that not everybody's going to be able to put a catheter in. Is there a simple solution to this?
Yeah, I wish I had a good answer. I mean, I think that if you have the capability, if you have the tools available, then I think that, and that includes the wide range of tools. You have multimodal analgesia available, you have regional anesthesia available, you've got catheters available when they're indicated, you have these other newer innovations, which you all do at UCSD. I think you're in a very, very different setting than most of our colleagues. I mean, I think there was actually an AQI study using a study using data from the AQI that Rodney Gabriel did a few years ago that looked at knee arthroplasty. Knee arthroplasty is performed 700,000 times a year. It's one of the most common operations in the world. And even if you look at an anesthesia-based database, the ASA's AQI, the use of a nerve block is maybe 1 in 4 patients. So, and that's any kind of nerve block. We're not even talking about catheters. So I think that access is a huge problem, and that's why I mentioned that earlier. But the way I interpret these data, I actually think that in some ways, it's not perfect, of course, and I think that we're looking at a small sample, but I think it says something, and it may explain why we see the results from other studies that don't always seem to make sense because we haven't had context. So for example, Brian Ilfeld did the mastectomy study. This was a randomized placebo-controlled infusion study. The patients received a home catheter for a few days versus placebo, local anesthetic versus placebo. Interestingly, in that study, he did a 1-year follow-up, and the patients who had local anesthetic actually had a lower incidence of persistent pain after mastectomy, which is a big problem. And if you look at now look back at the trajectory analysis and say, well, those patients, even with placebo infusion, have this downward trajectory such that in less than, roughly in about a week, many of those patients, or a good number of those patients, fall below the moderate pain range. And that's the placebo group. So you can argue then that perhaps when the targeted intervention, the local anesthetic infusion, extends long enough to cover the period of severe to moderate pain, perhaps that is actually what will predict better longer term outcomes. Like I said, these are all ifs, right? So but that's one way to interpret it. The other way is looking at the first panel in the top. Many interventions in knee arthroplasty, at least in regional anesthesia literature, have not shown long-term outcome benefit. We looked at data trying to find out if there's any, if you get a block, and a block can be a single injection or catheter. Does it decrease the use of chronic opioid use? Does it improve long-term functional outcomes? And even this study, with Brian led a 1-year follow-up of these patients to see whether their functional outcome improved using a WOMAC. And guess what? It didn't improve. But if you look at this and you say, well, even if these patients had a 4-day infusion of local anesthetic, and that's already arguably one of the best interventions you can offer a patient having knee arthroplasty. That still puts you midweek, right? where those patients sit in this moderate pain range for at least a week, if not more than a week. And a subset of those patients from Professor Lavendome's data suggests that some of those patients go on to have chronic pain. So I would argue that even though we we have so many debates about single injection versus catheter for knee arthroplasty, really what we should be talking about is perhaps an intervention that lasts at least a week. And so at least here, we actually have a very low threshold to give people a week-long infusion for knee arthroplasty. If there's a suggestion that those patients have not completely moved into the moderate pain range by day 3.
Dr. Mariano, I want to go ahead and, before everybody logs off for their clinical duties, just say thank you on behalf of everyone for such a great lecture. That's certainly echoed here in the comments by, it looks like, some of your former trainees. And again, we really appreciate it. I'll let anybody that wants to stay on and say hello to you if you have the time.
Sure.
Stay on. We'll keep the meeting open. But again, thank you so much. And to also echo what Dr. Finneran said, we would love to have you back and see you in person and take you out to a nice dinner if we can. Once we're
I'd love to come down there. Yeah, I'd love to come down. So when all this is behind us, or at least we have a better idea what to do with it, then I would love a tour of the new hospital.
Any Wednesday you want. Thank you so much again, seriously.
Thanks, Cody. Thanks for inviting me. I'll stay on for a little bit. I don't have a meeting until 8, so I'll stay on for a little bit if anyone wants to stay on.
Dr. Mariano, I have a